Dear colleagues, we are starting with this seminar. Hello, good afternoon. I am Diana Nevzorov, and I am the oncologist and director of Federal Research and Practical Center for Palliative Medical Care, and head of the Educational Institution of Higher Education for Palliative Care under the first Moscow State Medical University, the Sechenov University. Dear colleagues, today we have a unique opportunity to welcome the prominent Dr. Robert Twycross, our great colleague, partner and friend from Oxford, member of the Royal College of Radiologists, indeed a teacher in palliative care, in Russia. Dr. Twycross, together with Dr. Zorza, were the first to initiate and indeed inaugurate the palliative care course in St. Petersburg in 1991, which was the landmark of starting palliative care specialty in Russia, which is now over 30 years ago. And this very first educational course became the starting point, the first step in opening the first hospices, first courses. And of course, Dr. Twycross is a true eminence in the field of medicine, head of the World Health Organization Collaborating Center for Palliative Care, research fellow in Therapeutics at St. Christopher's Hospice in London. So also the medical director of Sir Michael Sobell House, Churchill Hospital in Oxford. Dr. Twycross has taught in nearly 50 countries and has written over 300 articles, chapters, and editorials. Dr. Twycross attended the opening of our center in 2019 and co-chaired and participated in a number of our conferences, seminars. He supported creation and establishment of our association in 2013. Dr. Twycross visited Russia and indeed toured several of the Russian cities. He also attended the Samara meeting. We know and remember all that. We have great memory. We hope so. And we are filled with gratitude to you. We are truly obliged and grateful to you for your indeed outstanding contribution to the establishment of the palliative care service in Russia. At the initiative of Robert, Dr. Twycross, we decided to have this lecture and propose it to those persons, to those professionals who are developing palliative care in the Russian regions, in the subjects of the Russian Federation. And today we have over 200 persons attending, both pediatrician and adult palliative care. This was our design. We decided not to confine ourselves to just the heading specialists, but to have a wide audience. Hopefully we can have a short exchange after the lecture has been projected and has been broadcast. Please mind your microphone for it to be mute when you are not speaking and for it to be on when you do speak. When you have comments and questions, please use the chat box, and we shall always give an opportunity to use and to have a word. So I would like to propose to start. Mark will interpret for us here. He has worked with us for a number of years, and we're always thankful. Thank you. Thank you. Thank you very much for your assistance. Dear colleagues, we're just about to start with the lecture. If I have forgotten anything, please prompt.
Could I say a few words?
Я хочу дать слово Роберту, да.
It's wonderful to be with you. If I could be informal, as Diana said, it's 32 years since I first came to Russia. She said St. Petersburg. Well, in those days, it was Leningrad. So a long time ago. And I have many friends in Russia and many friends in the former Soviet republics. So it's wonderful to be here. Diana said a lot of things about what I am, but most of them is what I was. For those who don't know me, I'm 82 years old. So, you know, it's a few years since I worked as a clinician. So that's point one. I might be totally out of date. So if at the end of the lecture, you want to say, Robert, that was all rubbish, you're entitled to say so. After all, we're colleagues and we can be straight, we can be honest with each other. The other thing is that because it's probably about 20 years since I looked after patients, I've been able to think rather than just act. And as you'll see, I've been able to reduce palliative care to 3 words. So that is something I couldn't have done 20 years ago. And those 3 words you'll hear shortly, and I hope will stay with you and stick with you and help you. But remember that I live in one country, you live and work in another, and the circumstances, the degree of development of palliative care is vastly different. So again, you must be prepared to say, but it's not like that here. It's different. And then tell me in the discussion, you know, put me right, okay? So, well, I think, oh, no, I must say one other thing. First of all, thank you, Diana, for the invitation. It's a great joy, I'm not able to travel anymore, so it's a great joy to be able to do it this way. But I also must mention Anastasia Ustinova, who has been wonderful in helping with the preparation of the slides. It's been a very creative activity, and without her, it couldn't have been done. So thank you, Anastasia, for what you've done and what you are doing. So with those cautionary words, then I'll hand back to Diana.
Роберт, а мне уже и слов нет. Пропали они слова.
Robert, no more words. I'm just so elated to see you. So let's pass on to the lecture. And use the time we have, if we're ready. I hope we are.
So let's begin. I've been involved in palliative care for 60 years because I first became interested even as a medical student at the beginning of 1963. So in a sense, what I'm going to do today is to reminisce, you know, just throw out a few thoughts which have come to me over the last 60 years. And I hope some of it might be of interest to you. So let's see where we get to. Right. If you had to describe palliative care in 3 words, what would you choose? Well, I have chosen non-abandonment in big letters, coupled with partnership and rehabilitation. And those 3 concepts will recur throughout my presentation. But notice non-abandonment is out there in big letters. So, but first, some history. When I was a medical student and young doctor, I was taught a traditional saying: a doctor's vocation is to cure sometimes, to relieve often, to comfort always. But as I look back, during the last century, and a bit before and since, the ability of doctors to cure has increased dramatically. And of course, our efforts have focused on that because that makes most sense. But it meant, certainly in the second half of the last century over here in the United Kingdom, that the comfort always, the care of the dying, was neglected by doctors. Now, when you get such an imbalance, here we are, here's the imbalance, cure right up in big letters, and comfort always almost microscopic. When you get an imbalance, usually some counter effect comes into play. And here in the United Kingdom, the person who enabled us in the United Kingdom to redress the balance in medicine was Cicely Saunders. She was a nurse, then a social worker, and then she became a doctor, training during her 30s and qualifying in 1957, but with the aim throughout that time as a medical student to found a institution, a demonstration model to show what could and should ideally be done to care for the dying. And that was to comfort always, the 3rd line on that traditional saying. It was in many ways a protest movement against the negative attitudes she had seen in the doctors when she was a social worker working in a teaching hospital, a university hospital in London. And she had a vision, and that vision was realized with the opening of St. Christopher's Hospice in South London in 1967. And her charismatic leadership led to, what shall I say, led to other hospices and palliative care units being set up during the 1970s and 1980s and beyond. I said a few minutes ago that I first met her and was first inspired by her in 1963. And perhaps it was not surprising that after I've completed my general internal medical training, I accepted an offer to work with her for 5 years in the early 1970s as a research fellow in Therapeutics. But over here, that meaning in the Russian Federation, I think the redressing of the imbalance began a bit later. And this, I think, was the beginning for you. A 2-week course, a residential course, classroom course for 29 hand-picked doctors from across the Federation. And that led to hospice, palliative care in your country. And you are now the people who have been appointed to take the need forward in your vast country. Just to make sure we're all talking the same language, Here's my brief definition of palliative care. It's holistic care of patients with incurable, progressive, life-limiting disease and their families. Holistic, addressing not only physical need, but also psychological, social, and spiritual. Now, it's fascinating that over the last 50, 60 years, palliative care has spread dramatically to almost every country. And the World Health Organization, they, in their Health Assembly in 2014, said, we need to provide integrated palliative care in the context of universal health coverage. And you know what that means. It means that it should be freely available for little or no cost to the whole population, both urban and rural. And I know that's a challenge you have undertaken, and I know that you're going to continue to see big advances over the next years. Now, because I'm a teacher, I have put this slide up because medical students learn principally on the second column, biomedical model. And they perhaps get an unbalanced view of medicine. And I wanted to point out to them that palliative care, the third column, was distinct from what they were seeing around them in their teaching hospitals, and it differed in a number of respects. And I want you to concentrate not only on the intent and the goal and the focus, the first 3 lines, but the role of the doctor, the penultimate line. In biomedical care, the doctor is the boss, but in palliative care, he is the partner, a partner, and I'll come back to that. And of course, when you look at the bottom line, biomedical medicine is focused on preventing, avoiding death, whereas in palliative care, we are more accepting of death, and we don't put any further medical impediments in the way of a natural dying. Now, this is an aside. The left-hand box is original palliative care, end-of-life care, principally in the old days, people with cancer, now far more comprehensive end-stage disease of any description. But you see, it cannot, it seems, stay confined in that particular box, and it moves laterally to other neglected areas, and it also moves upstream. And in many oncology centers here, we have shared care where necessary. When someone who is having oncological treatment and perhaps major problems with pain or nausea or breathlessness, then they can have palliative care input, the skills of the palliative care team, alongside the skills of the oncologist. And in different countries, the neglected areas differ, so what gets tagged on to palliative care will differ. But I was pleased to see that in Yaroslav region, there is the House of Mercy, where you have 30 beds for palliative care alongside 30 beds for long-term nursing care and 30 places for assisted living, but all operating along palliative care principles. And maybe that's going to be one of the major ways palliative care spreads in your country as it spreads its wings. We shall see. So let's go to the three key concepts: non-abandonment, partnership, rehabilitation. First, non-abandonment. Now, Cicely Saunders said, the attitude we have to show to our patients is, you matter because you're you. You matter to the last moment of your life, and we'll do all we can, not only to help you die peacefully, but to live until you die. That is the attitude we have to demonstrate by our interaction with our patients, that they know that even though they're no longer economically useful or whatever, you matter because you're you. You matter to the last moment of your life. Now, one important message you have to get across to your medical students and young doctors is that it's possible to be abandoned when surrounded by people. And this is a short extract from Tolstoy's The Death of Ivan Ilyich. What tormented him most was the pretense he was merely ill and not dying. His physical sufferings were terrible, but worse were his mental sufferings, which were his chief torture. Now, that was written, 150 years ago. Has the situation changed? Well, it certainly hadn't changed completely in the second half of the last century. What about now? Well, this is from 18 months ago in a middle European country. A 64-year-old man admitted with COVID and pneumonia, and he died 3 weeks later. And he required sedation and intubation during most of that time, but not all. He was behind a screen, and when not sedated, he was able to write notes to his family. And he said, every day the doctors come and they talk about me beyond the glass screen. They point at me, but they never talk with me. Nobody introduces themselves. And he felt humiliated, a non-entity, worthless. I'm just a piece of wood for them. So making the point that you can be abandoned even though surrounded by people is an important starting point in training people about palliative care. So, abandonment, isolation, dejection, fear, despair, all leading to hopelessness. Now, there's a lot in the literature about hope, but I don't think it's always said that the primordial hope of human beings is not to be abandoned. You know, when life is challenging, you need someone alongside you to stick with you through the difficult time. Well, I believe this is human beings' primordial hope. So we have to stick alongside our patients so that they do not feel abandoned. And that restores hope. And that is, of course, the key to successful palliative care. So let's move up to partnership, and I've linked communication and teamwork with that, and just have a few thoughts about that. Partnership. Well, you can understand that if you're in partnership, good communication is the key. We have to listen, we have to explain, we have to find out what the patient's priorities are, and there has to be shared decision making. So, it's a partnership between experts. In relation to the disease, the experts are the healthcare professionals, you and your colleagues on the healthcare team. In relation to the impact of the illness, it is the patient and the family. Now, important it's important to remember that another way of looking at partnership is relationship-centered care. And we must remember that relationships are based on trust. So if we are to help our patients through partnership, through non-abandonment, we have to establish trust as rapidly and as fully as possible. And here is Kate Granger, a geriatrician with ovarian cancer in her 30s. And she was in and out of hospital, as you would expect with ovarian cancer, this treatment and that treatment over a period of years before she died. And what upset her most was the fact that people would come to her bedside and they'd say, "Oh, I've come to do this." And they would not introduce themselves by name. And she wrote that introductions are more than a common courtesy. It's about making a human connection. They begin therapeutic relationships and can instantly build trust in difficult circumstances. Now, I'm a patient too, as well as a retired doctor, and I know how upsetting it is when healthcare workers of any description do not introduce themselves by name. So if you want to establish trust quickly, note what she says, they begin therapeutic relationships and can instantly build trust in difficult circumstances, then please introduce yourself by name. There is a literature on relationship-centered care, which expands on the partnership model, and they place empathy and genuineness before partnership as, I guess, the groundwork on which partnership can be created. So let's just have a few words. Empathy, imaginative alignment. It's an innate cognitive and emotional ability to imagine what someone may be feeling. It's innate. We all have the potential. In some people, it is highly developed from early years, but in most of us, it can be developed by listening to patients' stories. And we begin to imagine what someone must be feeling, what someone might be going through. So empathy, if you like, is the bottom line of relationship-centered care, of partnership. But they also wrote about genuineness. And as someone said, people trust you when they sense you're genuinely interested in them. Well, I could talk about empathy and how to enhance empathy, but I'm not sure that I could tell you how to teach genuineness or how to enhance genuineness. Perhaps you can tell me, but genuineness seems to be essential. So empathy, genuineness, and then we have the groundwork necessary for partnership. So a bit about teamwork. Two pictures. The top one has a doctor, a nurse, and a therapist, probably, I think, a music therapist, but therapists include physiotherapists, occupational therapists, psychotherapists, as well as music therapists and art therapists. And what you have on your team, of course, depends on your financial resources, I suppose. Our hospices, yes, they have government money, but they also have charitable monies. And therefore, we're more able to employ such people as music therapists and art therapists to help with the patients who find it more difficult or too difficult to express their feelings and their fears through words. But at the bottom, we've got volunteers. Can you tell me, in that bottom picture, who are the patients and who are the volunteers? Well, that's our day centre. We're very fortunate to have a day centre here in Oxford. And we have patients, perhaps a dozen, 15, coming in Monday, Tuesday, Wednesday, Thursday, Friday. And they come in usually by a volunteer driver. They arrive 10 o'clock and they leave 3 o'clock or thereabouts. And they have a day when the relatives back home can have a day off. And of course, it means they can be reviewed weekly. If the nurses sense that there is need for medical review, then that is possible. But it's also the sort of heart of the social side of hospice, because the patients who are in the hospice who are inpatients, but they're well enough, they can come through to the day centre and join in whatever activities there are there and benefit by the social interactions. Now, we have a tradition of volunteering in the United Kingdom. I imagine you two have one as well, but ours is very well developed, which is fortunate because we use them a lot in palliative care. They obviously have to be screened, have an introductory course, and then some are accepted, some are not. And then they help in ways which fit their particular skill set. So, volunteers, yes, they have another advantage because people are in a hospice and, well, are they cut off from the community? Is it a death ghetto? But if you've got volunteers involved coming in from the community, then it illustrates that the community as a whole still care about you. So volunteers, if you're able to have them, are a great asset. Teamwork. Well, this is a doctor who has worked in palliative care for many years, who recently wrote, "I'm trained as a specialist in treating physical symptoms. In psychosocial and spiritual matters, I'm a generalist." Now, note, she doesn't say, "I'm a specialist in treating physical symptoms. I can leave the psychosocial and spiritual matters to others." No, we have to become more and more psychophysicians. But of course, there are those patients whose needs are greater than we can cope with as doctors trained in physical symptom management. And when patients need more, then of course they need to be referred on to the appropriate member of the team. But we are not just symptomatologists. So, communication. The essence of good communication, the essence of good communication is not what we say, but how we listen. One of the main aims of a consultation is to elicit a patient's concerns and fears. So, let the patient set the agenda. And this is quite different from how we used to be taught, maybe we still are, to make a systematic inquiry of the patient's disorder and come up with a picture of what may need to be done. But here it's partnership. Let the patient set the agenda. And these are just a few ways you can have open-ended questions. Open questions. Now, most of my patients in latter years were seen first as outpatients. And what I used to say almost always was, what do you hope will come out of this consultation? Now, obviously, sometimes it was, well, pain relief doctor, or it's a nausea doctor, or I can't sleep doctor, or this or that. But sometimes it was something very different, like peace of mind doctor, or I want to be treated as a whole person. Well, this is perhaps why I moved from being a specialist to a generalist. But when patients come with that sort of initial, that's what they want to talk about, then ask for clarification. What do you mean by peace of mind? What do you mean by wanting to be treated as a whole person? The person who said peace of mind was a man who lived in a single room rented from the owner of the house, a woman. And peace of mind to him meant that when he became too ill to care for himself, he didn't want to be burdened on the house owner. He wanted to be assured that he could be admitted to the hospice. So peace of mind, very practical, not necessarily the need to call the priest. In fact, far from it in this case. So I guess that takes us on to rehabilitation with its two wings of symptom control and psychosocial support. Rehabilitation, what does it mean? It means maximizing a person's potential. Now, we've already thought about the fact that there are various domains, physical, psychological, social, spiritual. So the aim is to maximize a patient's potential in all those areas. In other words, enabling people to live as fully as possible until they die. The left-hand picture is of a volunteer doing nail varnish or whatever, and the other on the right is probably an art therapist working with one of the day center patients. But of course, relieving symptoms often leads to a dramatic improvement on the short term. I know there are exceptions, but I've had people who I thought would die within 1 week or 2 weeks of coming to my outpatient clinic, who actually lived more than 2 years, who went home but attended the day center until nearly the time they died. Now, physical rehab is possible for a lot of our patients, and I'm sure it is what you see in yours as well. So, holistic clinical care, the 4 dimensions, but notice, as I've hinted already, all physical symptoms are somatopsychic. They start in a physical hurt, but they're always modified by the mind, by mood, morale, and meaning. And that's why we have to be more than a narrow symptomatologist. Why Cicely Saunders gave us this model of total pain: physical, psychological, social, and spiritual. We have to become more and more psychophysicians. Now, this is a slide which I use with the medical students just to summarize symptom management. And there are certain aspects which I want to emphasize. Explanation, the second line, explanation. Explanation is absolutely vital, because if a patient is full of fears because of this and that, to have a simple explanation of what is going on can reduce the fear considerably. And it also enhances the likelihood of adherence to the treatment you recommend. Now jump down to the penultimate line, which is monitoring. Review review, review. Now, often doctors are able to say, well, here's some tablets, come back in a week, come back in a month, and we'll see how you're getting on. But you can't do that in palliative care. Review may be necessary after 1 hour, 2 hours, 4 hours, 6 hours. Usually, certainly the next day, ideally, ideally in person, but in practice probably by telephone call, because you cannot gauge exactly how much medication they may need, and you don't know how they're going to respond to it. So review, review, review is crucial. Well, attention to detail, that is the sort of golden thread which goes through the other 4 aspects of symptom management. Now, attention to detail should be part of any professional, not just medicine. Any professional should demonstrate attention to detail. For us, it means asking why this woman has breast cancer. Why is she vomiting? Well, there may be several reasons, as you well know. And of course, depending on what the reason is, then the choice of antiemetic may differ. So we mustn't make unjustified assumptions. We have to make sure all the pieces of the jigsaw puzzle fit together. Now, I just want to say a few words about evaluation of pain. Confirm the site of the pain. That is so important. I've seen so many patients suffer because the doctor had not confirmed the site of the pain. I've got pain in my abdomen, the patient says, but the abdomen is quite a broad area, and it does, the likelihood of what it's caused by will differ if it's in the lower abdomen than the upper abdomen and so on. And if I've got pain in the back, the important thing is to confirm the site of the pain by asking the patient to point to where the pain is, and then confirm by placing your own hand on that site and saying, is this where the pain is? So while you're doing that, you're thinking, what is the cause of the pain? Is it the cancer? Well, I suppose that's the most likely, but could it be another disorder? Could it be frailty? Could it be treatment, past or present? And all those are possible. And of course, as in other areas of medicine, a lot of the diagnosis is on the basis of probability and pattern recognition, with investigation to confirm when necessary. And this is an article I wrote quite a while ago, but it was translated into Russian, I think 4 years ago. If you haven't seen it, I recommend it. I think it's a very useful teaching tool because it's got several case histories and it deals with various aspects of treating pain and the need to treat it as a somato-psychic phenomenon and not just a physical phenomenon. Now let's look at the patient here. Here she is. I was asked to see her on the surgical ward 10 days after laparotomy. It was what we called in those days an open and shut laparotomy. In other words, she was found to have disseminated inoperable pancreatic cancer, and she was sewn up, returned to the ward, but she had a good post-operative pain control, or so it seemed, injections of morphine and then converting to oral morphine. But then 10 days later, when I saw her, she was on 25 milligrams of morphine 4 times a day and still in pain. So I sat down, introduced myself, of course, and then said, "Where is the pain?" And she pointed to her upper abdomen. We talked about it, and we distinguished between a constant pain, that is pain number 2, and an intermittent pain, that is pain number 1. But when we'd finished talking about those, because I know that 80% of those dying of cancer with pain, 80% of those have more than one pain. So I say, and do you have pain anywhere else? And so we went on. We ended up with 6 pains. And then I said to the nurses and to the patient, I said, well, this is what we need to do. Read on in the paper. I came back 18 hours later, and instead of a patient in pain who was distressed, drowsy, and couldn't sleep, there she was sitting up, and the nurses were tending to her. They were all smiling and laughing. And I said, how is the pain? She said, I haven't got any. I didn't do any magic. In fact, I reduced the morphine and added in did several other things. I think particularly talking to the patient and the nurses about the fractured rib, which of course, if they don't realize is part of the problem, then the patient is going to be in agony when the nurses try to move the patient for any task. So there we are. Most important. Now, this may be too brief to make sense, but the World Health Organization, they, in the 1980s, popularized the 3-step analgesic ladder, which was non-opioid, step 2, add weak opioid, step 3, substitute strong opioid, and you may or may not have adjuvants alongside it. Well, that was very useful at the time, but people can get hooked on it, if I can put it that way, as they did with the patient we've just referred to. And I think it's better to put another model side by side with the analgesic ladder, which is non-opioids, opioids, and adjuvants, and recognize that sometimes the non-opioids are stronger in terms of relieving the patient's pain than an opioid, and sometimes it's the adjuvant medication, for example, antidepressants and anti-epileptics used for various types of neuropathic pain. Sometimes you need 2, and occasionally you need all 3 varieties. So we have to have what I call broad spectrum analgesia. Now, just before we close, let me say a few words about spirituality, because we've talked about physical, psychological, social, and spiritual. And yes, here we are. Spirituality is about how people seek meaning and purpose in life, and the way they connect to self, to others, to nature, and to the transcendent, to God, to ultimate reality. Now, the first thing to note is that religion and spiritual are not synonymous. On the left-hand side, we have an image of religion. It focuses on a set of beliefs and rituals, but spiritual focuses on personal beliefs. So, spiritual care, generalist spiritual care, attitudes, actions, that basic message of you matter because you're you, showing respect to our patients, treat them as people of worth with dignity. And basically, spiritual care begins with kindness and active listening and being prepared to reflect with the patient about meaning and dying and death, even religion, if that's what they want to do. And often that's all they want to do, just to talk about it. But sometimes we need to suggest, well, would they like to talk to a priest or a spiritual counselor, whatever you have. But remember, not all priests are good at spiritual care if they feel their contribution is limited to the church's ritual. Anyway, how do we elicit spiritual concerns? That first line, at the moment, what causes you the most distress? Well, you could start your whole consultation that way. So again, it shows that asking open questions, can lead you anywhere. The first question is clearly important. I think the second question should come perhaps in that initial consultation. The third question may well be put by another member of the palliative care team, but it needs to be asked by someone. It needs to be documented what the answer is, and is it supportive? Because there are some forms of religion which, to put it bluntly, are toxic, and they magnify fears and anxieties. They do not bring peace and contentment, if I could put it that way. So that is all important in our holistic care. So now, compassion means recognizing a person's suffering, rolling up your sleeves and doing something about it. But if on this slide we go back to its linguistic origins, comes from two Latin words which mean to suffer with. Now, when you look at it that way, you recognize that compassion is not primarily about finding a solution. It is about being willing to stay alongside a person even when there is no solution. We're saying, in effect, there's nothing I won't face with you. Together we can get through this. Non-abandonment. Now, this is a quote from a palliative care doctor years ago, in fact. And of course, because we're used to doing things to fix things, and we can't always fix things in palliative care, but we can stay alongside, she said, and it's a beautiful quote, "Slowly I learn about the importance of powerlessness." Wow! The secret is not to be afraid of it, not to run away. The dying know we're not God. All they ask is that we do not desert them. So, to round off, 3 key concepts: non-abandonment, partnership, rehabilitation, and 3 attributes to add to those concepts. Palliative care may be low tech, but it's high skill. No doubt about it. It's no place for failures. There's also need for a sense of urgency. Some patients coming to palliative care have been in great distress, in agony, for weeks, if not months, and they may not have long to live. So we have to have a sense of urgency. We don't have a waiting list. Well, we'll probably see you in a couple of weeks. A sense of urgency is vital. I would say palliative care is a form of intensive care. And as one colleague said recently, a form of intensive caring. Thank you for listening.
Роберт, спасибо вам большое. Дорогие коллеги,
Robert, thank you very much indeed. Thank you. We have a chance. Yeah, Robert, would you please switch on your camera? If yes, Nina Shmelov has. Will you introduce yourself, please? Ah, your mic is off now. Nina Khmelov from St. Petersburg. I attended Dr. Twycross's course in 1991. And in a year, I was fortunate to visit Sir Michael Sobell House, Churchill Hospital, and we have seen a lot since then. We have gone through much, but I still remember this most unique experience, and I remember everything I learned and the wonderful exposition I had being there. We remember our meetings. We certainly teach following, and there's a passage from his book about his feelings of saying farewell to Jane. And we talk to students about these passages from the book. And some say that if we had had such intelligent nurses, we would have fared much better. But hence my question is, what is your approach towards formation of an ideal team? How, what would you say, what would you counsel as to building up a good team?
So, right. Lovely to see you again after all these years, and thank you for what you've just said. The reference to Jane, that was Victor Zorja's daughter who died under my care in 1977, and her parents wrote a book which over here is called Death of a Daughter, and it was published also in Russian, as you know. So the basic palliative care team, I think, well, obviously, if you're the only person in the world, it has to be you. But I think a nurse and a doctor can do, probably 95%. And then, of course, depending on local circumstances, you expand it. A social worker and other healthcare professionals which are available to you in other specialties. But a doctor and a nurse, I couldn't have done what I did without trained, expert palliative care nurses of high caliber. And I don't know what the situation is in your country, but I'm sure you must be doing the same, training nurses as specialists in palliative care.
Thank you very much, Robert. Thank you.
Коллеги, сейчас у нас на...
Thank you very much. Thank you, Robert. Thanks a lot. Colleagues, you have sort of time for reflection, and Robert has asked to respond to these two questions. What aspect of the lecture has been most interesting, and what will you change anything in as a result of this lecture and discussion? Are there questions or comments? We can see the slide, but the voting window has disappeared.
Татьяна Владимировна, я думаю, как только вы отвечаете на
I think
голосование,
that the format is that once you vote, the window disappears. All right. Colleagues, some colleagues say that the window was very short-lived for them to answer questions, so they've asked to put it back. Dear colleagues, let me also draw your attention to the chat box, which contains references to the articles that Robert mentioned. The reference is the link was provided, and alongside with the PDF memo or a memorandum in PDF format with the issue of this journal. There are comments or questions. Robert is with us. All right, this window is back to vote. I voted and I submitted it. Oh, that's rather not a voting window. It was rather a poll. Good. We did it. We coped. Robert, our attendees are actively responding to this little questionnaire. I have a question, Robert, if I may. My question is about the pain which is hard to manage. Over the past 2 years, we are now sanctioned by law to administer peroral morphine. This has now become available. Given that our physicians and doctors, many of them never had experience of working with peroral liquid short action morphine, and that's a solution in a plastic one-use, single-use plastic container. We are reading in literature that non-invasive peroral morphine are more high priority in treating breakthrough pains and the hard manageable pain. And there's a lot of discussion going about this liquid morphine. Could you comment on this?
In fact, it's very difficult for me to comment because your situation is so different from ours. For some reason, in the early 1990s, the long-acting or slow-release morphine became available, maybe to a limited extent. And I know it wasn't until about maybe 4 or 5 years ago that the liquid immediate release morphine came to your country. So we did it the other way round. And, you know, I think you have got to take your situation and how it has developed, and you have to say, this is how we use it. You know, Diana, you must have a pattern of use. You may say, well, we don't actually need it. But on the other hand, I would be surprised if you don't find some use for it. And obviously, if you're using it for what we call breakthrough pain, then immediate release morphine, which will perhaps act in 20, 30 minutes, is better than a slow release morphine, which doesn't peak in terms of plasma concentration for 2 to 3 hours or whatever. So, you know, there are some questions I can't answer for you. You have to tell me. So sorry to be evasive.
Спасибо большое. Дорогие коллеги, есть ли вопросы?
Thank you very much indeed, Robert. Thank you. More questions or comments? Talking of palliative care and the importance of communication with the patient, I thank you very much for mentioning the book, Jane, the book that has been published in Russian translation. That is indeed, I would say, #1 textbook for palliative care doctors and nurses, and I certainly agree with Robert on the paramount importance of communication, individual approach, the setting of priorities, the limits of what is acceptable in the specific country and region, what is habitual, what is to be expected. And today, let me inform you, Robert, we are having more and more palliative care departments at hospitals. So the number of hospices has not been rising, but we have a number of departments, and some of the patients are transferred to such palliative care units. And in this regard, my personal conviction is that palliative care in Russia has helped many of our colleagues working both for intensive care units and for ambulance medicine to see the new ways of helping these categories of patients, which is, I think, some sort of a safety belt. And I also have a comment. The system of palliative care, and that's what we call it in the Russian law, the system includes the hospices, licensed nursery homes, and hospital units with palliative care. And our colleagues sometimes have may be somewhat confusing hospice or palliative care. And sometimes palliative care doctors will say, we're not a hospice. Well, I think that this is a confusion. Robert, could you one more time comment on if hospice is palliative care, and to what extent is hospice a part of palliative care?
Okay, well, I think it differs from country to country, but in many countries, the two terms are synonymous. But for example, in the United States of America, it's clearly distinct because that was how it evolved. And the funding for hospice care, which was very much end-of-life care, limited to people with a 6-month prognosis or less, that came in 1983, and palliative care only emerged in the 1990s. And palliative care tends to be what it's called in the hospitals. But the hospices, which are mainly in that country home care, they don't always have an inpatient hospice, which is different from ours. You know, now I'm getting confused, but the point is, you have a distinction between countries, and if we have a freestanding hospice, I mean, we were freestanding. Well, we were tagged on to the edge of a university hospital, but it was distinct, and from the public point of view, it was useful to call it a hospice, and for fundraising point of view, it was useful for calling it hospice, but the funding is all very similar within the National Health Service. So it's both an artificial and a real distinction, and you have to decide how you're going to use the terms in your country, but in many countries, they are used synonymously.
Спасибо, Роберт. Ну, согласно нашему
Thank
законодательству...
you very much. Indeed, by the Russian law, these are synonymous. And in this sense, I can indeed comment on this. If there are questions, may I avail of the opportunity and ask one other question? The book that we have discussed, it's not just a textbook. I first read it 30 years ago, and then reread it not long ago. But with the years, we rethink a lot of that is said in this book, and there may have been some apprehension that palliative care doctors become less responsive to suffering. But let me quote Robert, who said it years ago in the conference that I attended, and also it is expounded in the book. We, I think, become more responsive as palliative care doctors. We should not fear becoming less compassionate. I think we're becoming more compassionate, and I thank Robert as my teacher. That's my personal words of gratitude. Thank you. Thank you very much. Thank you, Dr. Khmelyov.
Thank you, Nina, for that. And I should warn people, if you're going to read the book which people have been referring to, which I have called by its English name, Death of a Daughter, the doctor in it is called, I think, Dr. David Foster or something like that. But that is just a pseudonym for me. I was the doctor looking after Jane. And I'm interested that you have found it so useful in your teaching. I think someone said it is the textbook. So I must go back and read it again myself. But this business of compassion, there is literature about compassion fatigue. And this particularly, I think, manifested itself during the COVID pandemic, which in many countries is still there. It's not over. It's grumbling on and erupts and then settles down. Now, you can have compassion fatigue. You can get exhausted. You know, it's linked to burnout. If you continue working excessively without adequate work-leisure balance, without adequate holidays, then you can, as we say in English, run yourself into the ground. And that is generally described as burnout. And I've certainly run myself into the ground on several occasions during my, whatever it was, 1971 to 2001. That's, I think, 40 years, isn't it? Or 30 years. My 30 years as an active physician. So, yes, you can burn out. And usually, because you are totally exhausted, you've emptied probably physical reserves, then compassion fatigue can come in. And we should be aware of that.
Thank you, Robert.
Роберт, у нас вопрос от слушателя.
Robert, we have a question from one of our participants, and I will try to comment why is this question coming up. Palliative care in Russia includes respiratory therapy, artificial ventilation, and financing of these types of therapies go through palliative care. Hence, the question from our participant: could you comment on respiratory palliative care in Britain, if any, as such?
Now, once again, I may not be able to answer in any adequate way for you because of differences between the two countries. But when I visited the Moscow Center for Palliative Care 4 years ago, I noticed there were a lot of patients who were on long-term assisted ventilation. Now, I'm not sure that you'd find that within the palliative care environment in this country. I can't say for certain, but I know that this is one way you have expanded the palliative care remit in your country, or certainly in many areas. And of course, if you have that, you have to work out, and I'm sure you have, when is it appropriate to discontinue that particular form of assistance. And because I haven't lived with that in my clinic experience, I can't answer. But we have to remember that we are not there to prolong the agony of dying, if I could put it that way. That certain treatments are there to support, well, the treatments we use are there to support treatment during the time they approach their natural death. So, you know, you have to reflect, is it appropriate for this patient to be on assisted ventilation? You know, has the time come when we should consider no longer continuing with it? Well, that opens up a whole, what we call hornet's nest of questions. Now, switching for a moment, of course, there is a lot of experience in our country of offering palliative care to patients, particularly with end-stage motor neurone disease. And I think that is probably a bit more clear-cut than perhaps just having someone attached to a machine and transferred to a hospice, because these people are definitely clear in their mind, and eventually a lot of these patients say, well, you know, I don't want to continue the assisted ventilation. And then, of course, they have the right to discontinue what has been keeping them alive, what has been preventing them from dying. And there are guidelines as to how to discontinue this assisted ventilation and allow, as we say, nature to take its course. And I don't know how it is for you.
Вот такой новый непростой вопрос и новый
Indeed, that's a very difficult question related to also the new technologies coming into palliative care. We do provide palliative care to patients who have respiratory support. Palliative care is not starting this, is not the source of such support, but palliative care certainly is extended to those patients who are on respiratory support or non-invasive oxygen support. Because these technologies are new to Russia, palliative care units help patients, but do not initiate such treatment.
паллиативной помощи. Мы опасались, что это прямой путь к
Indeed, we had a great anxiety as to how this would develop. So we're only talking about the support and help for those patients who receive long-term support. And if these are terminal end-stage patients, then we help them in the ambit of the multidisciplinary team. So to us, respiratory support is not about ongoing suffering of the patients, but indeed palliative care to those patients who have been put on respiratory support. And so every individual case is considered separately. Robert, this practice here has started with with pediatricians, with children's care, and this question has been much discussed and in the doctors' community. And in Russia, respiratory treatment has indeed started with the palliative centers. But today, the pulmonologists, neurorehabilitation doctors are seeking to help, are seeking, both legal and budgetary help. So thanks to you, and thanks to your contribution and the contribution of many doctors, we have developed this and taken this forward. It's not for mostly not for cancer patients. This is the trajectory of palliative care in Russia. Dear colleagues, we have 2 minutes before the end of this conference. We have questions about the development of palliative care under conditions of the rising need of geriatric care. Yeah, we will continue with these in our upcoming seminars, and Robert may not be qualified to tell us about Russian experience. You're to tell Robert about Russian experience. Dear Robert, on behalf of our association and the doctors community and myself personally, let us thank you and inform you that we have spanned countries and time belts in this conference. We have had people joining us from different places. Thank you so very much for being in this one audience, one conference, and to listen to the presentation and the lecture. And there is a stream of thanks to you in the chat box that I'm only so glad to relay to you. Thank you so very much. Yeah.
Thank you. Thank you very much again for the honor of being able to talk with you today. You know, an old man reflecting, and I hope some of those reflections may have been of interest. Thank you.
Ваша лекция будет размещена на сайте ассоциации.
Dear Robert, your lecture will be in the treasure of our teaching aids. Thank you very much, Robert. Anastasia.
Да, спасибо большое всем, кто
Thank you very
присоединился.
much. Thank you very much for joining.
И Роберту громадное спасибо за то, что он
Thank you, Robert,
поделился всей мудростью, которую он накопил за эти годы с
thank you for
с
sharing
нами.
us the wisdom. Thank you for sharing us
Невероятно
your
ценный
wisdom.
lecture. I want to share also the results of our poll about what question was most interesting and significant to our listeners. What aspect of your lecture, Robert? So more than half of the participants found philosophy of palliative care in general most interesting and important questions. Then the principle of non-abandonment was very, almost 50% found that important. Then goes teamwork and psychological aspects of palliative care and assessment and treatment of pain, also factors that affect the experience of pain. Next by importance is palliative approach and holistic care on every level of care that we can provide. And the last one is religion and spiritual care. And the second question about will you change something in your practice as the result of the lecture and discussion, 87% of our participants said yes, and 13% said no. So that's it.
Thank you.
Вот такие интересные результаты опроса. Роберт, спасибо
Very
вам.
interesting results. Very interesting for the initiative. And thank you for the initiative. We shall pick up this this tool, which I think is rather useful. Thank you, dear colleagues. We shall now conclude. Robert, will you say? Yeah, it's up to you to say. Bye-bye.
Thank you. Thank you once again. It's been a great pleasure, and I wish you well. There are big challenges. I know that big challenges, particularly on the back of COVID and other challenges. And I just look forward to hearing how you are progressing in a few years' time. Thank you.
Спасибо, Роберт. Спасибо огромное.
Thank you
Дорогие
Thank you very
коллеги.
much, Robert.
Спасибо, до свидания.
Bye-bye.